my name is Julie Wolfson, and I'm a pediatric hematologist, oncologist, and health services researcher. And I'm at the University of Alabama at Birmingham, in Birmingham, Alabama, and the Institute for Cancer Outcomes and Survivorship. And so my focus in my research is on health services and health outcomes. And we'll talk a little bit more about what that means in a second, I think.
So I'm Jennifer Levine. I'm a pediatric, mostly oncologist, a little bit of hematologist at Weill Cornell Medical Center in New York City. Primarily, I clinically treat children with leukemia and lymphoma, and my interests from a research perspective are actually primarily in survivorship and fertility preservation. So in ways they really overlap with some of the population sciences. But I think the fact that I'm involved with this also speaks a little bit to sort of how interesting it was how the project got off the ground.
I'm Emily Johnston, and I am also a pediatric oncologist and a little bit of hematologist at University of Alabama at Birmingham in the Institute for Cancer Outcomes and Survivorship. And I take care of kids with solid tumors, and then I do research on disparities in end-of-life care and how we can make sure that every kid who's dying of cancer has high quality end-of-life care.
So I'm in New York City, and of course, New York City was one of the areas in the United States that was really one of the first epicenters for the pandemic in the spring of 2020. And it really just came on in the city. Schools got closed, hospitals got transformed really into COVID hospitals. Pediatric programs were being redistributed to make room for COVID beds. And, we were starting to see some COVID in our patient population. And it's a little hard to explain, I think, in some ways, how absolutely unprepared any of us were for this kind of an experience. And I want to just actually, no, I can't, I have a screenshot of the origin of kind of how this all started. But when this was all happening, I sort of started thinking, wow, this is kind of crazy, and we really have no idea what it is that we're doing. And so, I reached out to my favorite, medical networking center, which is Facebook, and posted in one of the groups, which is actually a female-led pediatric hemonc group, and essentially said, this is crazy, like this, what's happening here, and should we be doing something about this, and like trying to share our information and moving forward and trying to understand this better. And literally the group of us that are studying this evolved from the people who responded to that post, one of whom was Julie, who I've known for a long time and really love working with. And a couple of other individuals who really have not a lot of research background, which I think is one of the things that's the most unique about this experience that we had, is that we were in a situation which for all of us was, clinically important, and we wanted to know more. And so the group that sort of came together is, I think, just a really unique blend of individuals who maybe would not have ever come together before. And literally, so this was March 23rd that I posted this on Facebook. And Julie said, well, I have this great colleague, Emily, who I think, might be interested in, let's talk about this. And so really rapidly, we came together and we constructed what we thought would be important information, essentially to send out to our colleagues. And really to say in the beginning that one of the things that I think was so important about this is that our goal was every 2 weeks to send out more information. So that what we wanted to be able to do was give in real time information to our colleagues about what COVID was looking like in our patient population, so that as the waves moved across the United States, they would have a better sense of kind of what they wanted to do. And I had pulled one of our, so we've been sending out reports every 2 weeks, and I sent out, had a picture, one of our reports was from May 13th, so 6 weeks later, and we had, so 6 weeks later, we had a report. We had 16 patients who were enrolled, 19 patients who were enrolled, and greater than 50 institutions. that had signed up to try to get this through their IRB. So, I mean, it was this incredible labor of love, really. And I think commitment to our patient population and our colleagues to try to get this information out there. So, really, like, I think a unique experience, and one that was really just has been supported by the fact that we think that it's important to be doing this. And an effort that's really relied so much on the infrastructure that Dr. Bhatia has built in Alabama that allowed us to take advantage. And then from that, Julie and Emily have just really run with this project.
I have to say there was a funny moment that Emily and I had recently, because we now have over 1,000 patients and 95 sites with IRBs approved and patients submitted, and another kind of 10 that are pending. And we said, oh my God, do you remember when we reran the data like 3 times in 1 week, because we went from like 9 patients to 12 patients. And now we have, and the data would change a lot then. Now we have over 1,000 patients and almost 100 sites, and it's overwhelming how collaborative it's been and how supportive the institutions around the country have been. And like Jen said, I think the really important lesson that we've learned and message that we've gotten from everyone is that everyone really did come together when the chips were down and was willing to do what it took. I mean, we have a variety of people entering data, from the PI at the site to some people do have CRAs, to med students, to residents, to fellow. I mean, it's whatever it took to get it done. People felt like it was really an important mission, and they were willing to contribute in any way they could with their elbow grease as well.
With that, I've been getting, as we send out these reports every 2 weeks, getting emails from people that are like, oh, thank you, this has really helped with our care of kids with cancer with COVID, because we've been blindly trying to help each other out, and really nice that that it has actually benefited people like we were hoping it was going to. I feel like we always feel a little bit like a mixed about having over 1,000 patients in our registry, because it's hard that we have that many kids in this country with cancer who are getting affected by this. But given the state, I'm glad that we can help contribute to the clinical care of these kids.
And it's been able to be a source of, I don't know, people write us with questions, just what have you heard about X? Does this group have guidelines? Does that group have, because they will assume that it will have come through us one way or the other. And while we can't give any definitive answers, we're happy to be a clearinghouse for that kind of information as well.
Yeah, so what we wanted to do was to design a registry that would really be able to impact clinical care and kind of let us know how kids with cancer and COVID-19 were doing clinically, and kind of how that was affecting their cancer care. So kind of designed the registry with that in mind. We also designed it to be able to get moving rapidly. As Jen described, we went from just talking about it to actually having patients 6 weeks later, which is unheard of in the research world. And one of the things we did was to design it to not have identifying information about patients, and kind of to keep things pretty broad, so we could just rapidly get patients into the registry, so we could get information for the community quickly. So the big things that we are collecting information on are the general sociodemographics of patients, to kind of figure out who is at risk of getting COVID, and who of kids with cancer are getting sicker with COVID, would help kind of helping with those questions. So a lot things about race, ethnicity, and insurance status to help tease that out a little bit. And then information about the clinical course of COVID-19 in these kids. So, what are their symptoms? How long are their symptoms lasting? How sick are they getting? And then the impact of COVID-19 on their cancer care, in terms of, are they having changes to their cancer-directed therapy, or scans that are delayed, or things like that, to know not only how sick are they getting, but whether or not their regular cancer care is getting delayed.
It's a really good question. I think I can, if you guys are okay, I can answer that. What we've been looking at is really how we can take care of these patients best, right? And I think we've really been able to help our colleagues do that. But now that there's two parts of where we need to go with this now. One is, we all know that the vaccine is a really important next step in what's happening with COVID, right? And kind of knowing who's getting vaccinated, how that's impacting their disease course, both in cancer and COVID, et cetera. And so we actually are expanding to include a vaccine registry with this as well, both for patients that have had COVID and haven't had COVID. But another part of it is that because Emily said we really designed this to get through IRBs really quickly, there's a lot of there's some really specific information that would be really helpful in actually being able to understand the patient's experience in much more depth and with just a few additional elements. And so the goal is to go back now and actually collect a little bit more in-depth data about those patients so that we can really drill down on some of the clinical course and the impact among in this patient group. So the goal is we'll expand the data that we're collecting, both with the clinical for describing their clinical course and the changes in their cancer therapy by being able to get a little bit of identifying information, and then also looking at vaccine uptake. So an IRB is an institutional review board, and so every university or hospital that's doing research has their own institutional review board, or they specifically say they're going to rely on another institutional review board, but it's the way in which we as institutions protect our patients within the process of research. And so interestingly, I think that there's some way, so I was going to think about the easiest way to explain it, because there's a couple of ways that patients can participate in research, and it's this really easy process for their institution to submit this piece of paper to their institutional review board, and it says, hey, this has already been centrally reviewed at this big central IRB, and it's kind of just a pass through. But when you're doing something from the ground up like this, and we were really kind of doing this, I'm going to say this was bedside to curbside, right? So we were really doing this on our own on a street corner almost. So we actually had, every institution had to submit their own individual IRB application, which can take a little bit of extra time. And I think that that's a euphemism for a variable length of time, if that makes sense. But it's the way that we protect, that the research world is set up to protect patients, and these evolved kind of out of the Tuskegee era after that, and so that we can protect patients within the context of research.
Yes, and right now we're collecting information about both changes in cancer care and how sick kids are getting, and we hope both of those will help clinicians, both pieces of information will help clinicians know, A, how worried they need to be when a kid with cancer gets COVID, and whether or not they should be changing their therapy. So just as an example, 31% of kids with cancer who get COVID are admitted to the hospital, which is about 5 times higher than the rate of admissions in the general pediatric population. So it appears that kids who have cancer and get COVID get sicker than other healthy kids when they get COVID. We've also found that kids who are publicly insured, kids with hematologic malignancies, kids with other comorbidities like diabetes or sleep apnea, and kids who are older than 11 are the ones who are most likely to get sick. So it's made me think that when I have a kid who has COVID, who is 15 with a hematologic malignancy, I need to be a little bit more worried about them and watch them closer and have kind of a lower threshold for making changes to their chemotherapy than I do a 2-year-old who has a Wilms tumor or another solid tumor. And we're working on kind of getting more and more of that information out to the community, so they, even if we're not quite at the point where we have guidelines yet, although we'd love to, that people can at least be making informed decisions about how closely they watch their kids with COVID and how they think about changes to cancer therapy with these kids.
And so some of the data that Emily is sharing is from the first paper that's going to come out from this project, which is imminent. We're revising it and sending it back to the journal as we speak. But because of the benefit of concern funding, we'll be able to now dive into a bunch of different subgroups of patients to really understand some of the nuances of what about the patients with specific types of diseases or having had a bone marrow transplant or the older AYA patients, and really be able to help with those, understanding those specific patients for our colleagues as well. And I think we've been able, the beauty, like we keep saying, of this is that we've been able to push the disease data out every 2 to 4 weeks and share this with our colleagues, but without waiting for this paper to come out, right? Like, I think that the traditional trajectory of research is such that people kind of protect that data and sit on it until that perfect paper is ready, and then until it's published, you don't say anything about it, because that's this, your capital is your ideas and your findings, right? But I think because this has been such a public health effort and collaborative as well, we've been able to push those data out, and the goal really is to help our colleagues. So I think taking all those data then to the next step and diving in deeper, I hope we do have something that people can use along the lines of guidelines when they see that these kind of more robust data, if that's fair.